So in this talk, I'll be talking about neuromodulation for chronic pain, and specifically spinal cord stimulation and its variations. And once again, I'll try to give an overview of spinal cord stimulation in the treatment. And just a reminder from my last talk, I talked about the WHO analgesic ladder. So before you start graduating somebody from mild or weak opioids to strong opioids, it's really the time to start looking at other modalities. And spinal cord stimulation is one of those. And in the realm of spine surgery, where you're dealing with the failed back syndrome and the failed neck syndrome, there's a big role for things like spinal cord stimulation. So, as I said, I'll be talking predominantly about spinal cord stimulation. It is the most common stimulation method that is used for the treatment of pain, and it's part of a spectrum of stimulation in the nervous system, going from proximal to distal. We can stimulate any number of the structures in the nervous system. And all of these therapies involve stimulating the large fiber or lemniscal sensory system, as opposed to other targets in the brain which target other pain systems. Spinal cord stimulation is useful for a number of chronic pain conditions. Failed back surgery syndrome for both the low back pain and the chronic radicular pain. Similarly for chronic arm pain in the setting of cervical radiculopathy. It's good for complex regional pain syndrome, peripheral neuropathic pain, such as can occur following a peripheral nerve injury, and various of the post-surgical pain syndromes like post-thoracotomy pain, post-herniorrhaphy, post-vasectomy pain, all can have their local chronic pain syndromes, which are in that category of pains where maybe it's just the wound healing, but over time it's clear that the pain takes on a life of its own. So, first of all, there's good evidence that spinal cord stimulation works. There's evidence that spinal cord stimulation works for both failed back surgery syndrome and CRPS. Taylor, in a systematic review of 74 studies involving 3,300 patients that underwent spinal stimulation for failed back, he found that 2/3 of the patients had better than 50% relief, 70% reported satisfaction, and there was a significant proportion of patients who were able to eliminate analgesics and return to work. Kumar reported that 3/4 of his patients with failed back and CRPS experienced more than 50% pain relief and significant functional improvement. There's also evidence that this benefit endures. So Kumar, when he looked at patients with spinal cord stim versus conventional management, showed sustained benefit at 2 years. Richard North compared spinal cord stim to lumbar reoperation in patients with failed back and showed persisting benefit in the stimulation group at 3 years. And Kemmler, who was comparing spinal cord stimulation and physio, compared to physio alone in patients with CRPS, showed benefit at 5 years. So we know it's efficacious. We know that the benefits can endure. It's also cost effective. Kumar, who is a Canadian neurosurgeon, studied this in the Canadian system and showed that when followed over time, the cost of spinal cord stimulation was cost effective, and that crossover point was somewhere in the range of about 2.5 years, when the ongoing cost of maintaining a stimulator was far better than the ongoing costs of maintaining medical management in this group of patients. He also showed that earlier intervention with spinal stimulation is better for patients with chronic pain. So the success rate, if you operated or started to do spinal cord stimulation early, was far superior than if you did it later. And overall, he came to the sense that, you need to get to these patients before their chronic pain had been present for 5 years or more. That's not to say operating on patients with long-term pain is not going to help them. It's just that your hit rate is better if you're going to address this pain earlier. So conventional wisdom has it that when we're using stimulation therapy, we need to produce paresthesias in the distribution of the pain in order to achieve benefit. So if we do this by putting an electrode over the spinal cord, we can achieve very broad areas of paresthesia coverage. So here's a pair of electrodes inserted so that they cover T8, 9, 10 in order to get low back and legs in a patient who has failed back surgery syndrome. We know that at different levels of the thoracic spine, a stimulator placed there will cover different areas anatomically. So with SCS, you can get fairly broad coverage. You can change the position of the electrode and place it over the area of the nerve root, and you can So as you put the electrode more laterally, you can stimulate the actual nerve roots rather than dorsal columns. So here's a patient who's had electrodes placed over the L1 and L2 nerve roots for the treatment of groin pain. And there you're focusing the stimulation over the area of their pain and not getting a lot of extraneous areas. Sacral root electrodes can be inserted either through the sacral hiatus, as in these pictures here, or retrogradely from the lumbar spine for the treatment of chronic perineal pain, for example. This X-ray shows cervical stimulating electrodes, cervical nerve root electrodes bilaterally placed in a patient with CRPS in both arms. So it's been our experience that when you're stimulating nerve roots, the electrode tends to be less positional, particularly in areas that move a lot, like your neck, and you're using lower stimulation thresholds. So ultimately in the neck, we've almost exclusively moved to using nerve root stimulation rather than spinal cord stim. It's also useful for discrete regions that are difficult to target with spinal cord, or you're only able to target them with the ability to target, with also targeting huge extraneous areas. So things like chest wall pain, abdominal wall pain, groin pain, perineal pain, you can target well with nerve root stimulation. The DRG, or dorsal root ganglion, is accessed by placing an electrode through the intervertebral foramen to stimulate directly over the dorsal root ganglion. This really has the same advantages of nerve root stimulation. That is, it's more discrete stimulation with less positionality and lower stimulation thresholds. And the data suggests that it's just as effective as spinal cord stimulation. There are now a number of stimulation paradigms that can be applied that do not produce paresthesias and yet still produce pain benefit. Dirk de Ridder in 2010 came up with burst stimulation, the waveform that's shown up in here. And this produced some stimulation in the absence of paresthesias and yet produced benefit. And there's now good evidence that high-frequency stimulation can produce pain relief in the absence of the production of stimulation-induced paresthesias. The first commercial system stimulated at 10,000 hertz. But it's now been shown that, stimulation at any number of frequencies higher than 200 or 300 hertz can produce a similar benefit without the patient having appreciable paresthesias. So to some degree, that also eliminates that subjective change in sensation they get when they move around. We presume that we're still stimulating dorsal column fibers, but the reality is that we really don't know the exact mechanism by which spinal stimulation helps, whether it's through tronic stimulation at less than 100 hertz or whether it's high-frequency stimulation. So the electrodes can be inserted percutaneously or by an open laminotomy. My preference is to do it percutaneously. So for a typical thoracic spinal cord stimulator insertion, the skin is punctured at around the L2 level. You're doing a double oblique trajectory so that you're approaching from a low angle and from off the midline. Introducing a 2E needle. The epidural space is cannulated about T12 to L1 or L1, L2, and currently I would insert two 16 contact electrodes. I put the tips at about T8 when I'm inserting for the treatment of pain in the setting of failed back. And I try to find a spot where we can turn on the stimulator, produce paresthesias that cover the pain area all the way up to almost the rib cage if you can, and all the way down into the toes. And we also make sure that we anatomically overlap the T910 area, which is purported to be one of the sweet spots for high-frequency stimulation in the setting of chronic leg pain. Now, in our center, we would typically do a two-stage procedure. So we put an electrode in, we trial it with an externalized disposable electrode, and then it gives us the freedom to run out an extensive trial if we need. So it may be as short as a week, it may be as long as 4 weeks, until we're convinced and the patient convinced that they're getting benefit. And then we simply get rid of the electrode, let them heal up a little bit, and come back and put a permanent system in. Other centers will insert a permanent electrode and tunnel it and externalize it, and then come back and use the same electrode, extend and attach it to an internally implanted system. Technology is continuously evolving in the stimulation world. There are now primary cell systems, rechargeable systems, a wide variety of electrodes for both percutaneous and surgical insertion, and different stimulation paradigms now. So work with the various frequencies and various waveforms is ongoing. There's now a closed loop system that has come onto the market where a couple of the electrodes in the implanted device are used to actually record the evoked potential from your stimulation, and it feeds back to the stimulator to maintain that evoked potential at a continuous level so that when people move, the stimulator automatically turns up and down to avoid them getting overstimulated, and it's starting to reduce this intensity of overstimulation or positionality. So to recap, I've tried to give some evidence that spinal stimulation is efficacious, it's cost-effective, it's applicable for failed back, for CRPS, for peripheral neuropathic pain. But I wanted to emphasize that it's not really a modality of last choice, which it has been regarded in many places. It should be considered when patients are not getting adequate relief from medications and before you start making the jump to strong opioids in these patients. And it's best used early rather than late, and some data suggest best used within 5 years of chronic pain onset. All right, thank you.